is mobile to answer to the mobile. But if somebody don't want to participate in the Kahoot, they can just listen the lecture. So it is their choice.
Thank you, sir.
Okay, so it's visible, no?
Yes, sir. Yes, sir.
Okay, so you can quickly the scan and join. So I'll be taking two part. First part, I'll be talking about the different causes, how those causes, epidemiology, and how those causes of those pathology are producing different kinds of signs and symptoms. This is the first part of the Kahoot. And second part, another Kahoot, where I'll be talking about the clinical methods, what are the ways to make a diagnosis by clinical examinations. And I'll be at the end, I'll be talking briefly about the different treatment outline. So those who are two devices, just with the mobile, you scan this, and it will be asking your name. You can put any name, whatever you wish, and I'll be expecting all of you to make it more interactive. And in between the whatever the quizzes will be there, I'll be asking you to join the participate the quiz as well. Bus only 6 out of 39. Those who are joining from laptop, they just quickly scan it and join with your mobile. And those who are joining with the mobile, so they can participate, they just listen the lectures. Okay, shall I start?
Yes, sir.
Okay, so let me start. So I'll be starting with a poll. Have you ever experienced back pain? Never, sometimes, often, and right now I am having back pain. Those who are joining late can be just use this game pin here. Okay, so you can understand only two people out of how much? 15, 17 people, only two people have never back pain. So you can understand what is the, the prevalence of the back pain. So literature says that lifetime prevalence is more than 85%. Means almost all of us, and from this poll you can understand at some point of time we feel back pain, and you can see out of this 17.3 right now have the back pain. So we can understand how common it is, and anybody who wish to be a good pain physician must learn the back pain, different causes of the back pain, how to make a diagnosis and plan management accordingly. So let us go with the steps. So clinical evaluation steps, it starts with the causes. Unless we don't know causes, we should not start evaluating the patient. So first, please remain muted. Okay. So you must. So first part of starting the evaluation, you should be learning the causes nicely. Out of them, those causes, which causes are dangerous, we call it red flag. And then in the history, the chief complaint, the present illness, the medical history, personal history, family history, occupational history, these are all history. This is not nothing special for the back pain. This is common for any kind of pain evaluation. And then the steps of the clinical examinations: inspection, palpation, range of movement, neurological examinations, and special clinical test. So the pain medicine initially it started with some interventions. Many of you must be knowing that pain medicine started. John Bonica, first multidisciplinary pain clinic, he opened in 1950s, and then pain medicine was basically, it was not pain medicine term was used that time. That time the term was pain management, and there we used to do some intervention, and we used to think that okay, this is my goal. But gradually, pain medicine evolved, and gradually these steps of the pain medicines, also we have defined it that what are the steps, like in cardiology, what are the steps? Inspection, palpation, auscultations, so percussion and auscultation, right? It's not the same for the musculoskeletal system. It's not the same for the neurological examinations. So clinical methods for the different specialties follow the different step-by-step approach. So the step-by-step approach for the pain medicine is your inspection, palpation, range of movement, full neurological examinations, and special clinical test. And then we should be doing some laboratory investigations. We should be having some imaging, and then we should be having the provisional diagnosis and differential diagnosis. Another important thing, what is there in our hand of the pain medicine, the pain physician, is your diagnostic intervention. With all those things, if your diagnosis is still not sure, if you are not sure about where from the pain is coming, to search the pain generator, another very important thing is to do a diagnostic intervention. We give the local anesthetic into the suspected structure or the nerve supplying that suspected structure, and we can come to a conclusion that this might be the pain generator if the pain relief is more than 50%, or maybe to be more precise, to be more than 70%. So this is one of our, we always feel proud to share these things, that the clinical method of the pain medicines book is the first ever book and the only book till now in the pain medicines, the clinical methods. So what is a pain generator? A pain generator must be having a physiological nociceptive innervation or a pathological innervation. What is the meaning of pathological innervation? So we must be knowing that our nervous system is not static. Our nervous system is continuously evolving, and we call this as a neural plasticity. That means, suppose if a blind person's brain cortex is examined, it has been seen that his visual cortex gets atrophied, whereas he need to live his life based on what? Based on touch, based on the tactile sensations, based on the auditory, by hearing. So this cortical area basically hypertrophied. That means based on the inputs what it is getting, our nervous system is continuously evolving, changing, and we call this as a neural plasticity. Cell bodies do not grow. No new cell body grow, but axons and dendrites can grow, and where there was no innervation earlier, those non-innervated part also can be innervated by the neural plasticity. So that means to be a pain generator, a structure must be having a physiological nociceptive innervation, like facet joint itself in the back, or it might be having a pathological innervation. Like example is inside the disc, except for the outer 1/3 of the annulus, rest of the 2/3 of the annulus and the whole of the nucleus pulposus do not have any nociceptive fibers. But in pathological conditions, in disc degenerations, the nerves grows in through and through, and they might be having a pathological innervation. So whatever it is, a pain generator means a structure must be having a physiological or pathological innervation. And if you are giving local anesthetic into that structure, the pain should go away. At least more than 50% the pain relief should be there. Then you can call it as a pain generator. So we'll be going for the back pain generators. What are the structures which have the physiological or pathological nerves and can be a source of pain? So very common, most common is your disc. Then second common is your facet joint. Elderly people, facet joint is the most common. Sacroiliac joint is the third common. Muscles are also very common. Earlier muscles was, not much, the publication was there on the muscles earlier. I'm talking about the 2 decades early, when this first, the diagnostic interventions and followed by this different epidemiological, results was there, publication was there. There the muscles was very, very few publication was giving importance to the muscles. But if you are looking about the recent publications over the last 1 decade, you'll see the multiple publications of the muscles. So muscles are giving more and more importance, and muscle and the muscle plane, interfacial plane, those are the areas which have been giving a lot of importance in the recent days. But still now, if you are asking me, based on the available literature, what is the commonest cause of the back pain? Commonest cause of the back pain will be because of the disc degeneration. Second common will be coming facet joint. But if you are taking only elderly people more than 60, the facet joint will be coming first. Sacroiliac joint comes third common cause, and muscles come as the fourth common cause. Other causes of the back pains can be ligaments, Vertebral body was also not given that importance earlier, except for the vertebral body fracture and the malignancy. Vertebral body as a source of the pain was not counted at all. But again, over the last 1 decade, a lot of publications are coming in vertebral bodies, particularly different kinds of modic changes, modic type 1 and type 2 changes, have been blamed that vertebral body, like disc, can also be a very important source of the pain. But again, statistics wise, that has not been done till now in the first or second position. First and second position in the disc and the facet joint. And third is your sacroiliac joint. Bursa and hip joint. Hip joint also should be always counted whenever you are evaluating a patient of the back. So again, a quick quiz. Already I have given the answer. Commonest pain generated in the lumbosacral area. This is just to see whether you are attentive or not. So it is disc. Commonest pain generator is disc. So now the second important question is also very relevant. Say for example, if the disc is the source of the pain, normal disc should not cause pain, or normal facet joint should not cause the pain. So only answering this question, where is my pain generator, you are partially answering the question. So you have to understand why a disc is a pathological and how it can present clinically, or why a facet joint has been converted into a painful facet joint. So along with this answer of this, where is my pain generator, whether it is a disc, answer is not, the complete. I have to tell what kind of disc pathology, what is the clinical, the presentation of that disc pathology, or what is the reason for the facet joint to become a normal facet joint to painful facet joint. So always remember both these answers are equally relevant. So now first we'll be starting with the disc. Number one is where is obvious the disc, and why. There are three important pathological conditions. One is internal disc disruption, one is disc prolapse, another is canal stenosis, and they all not the same. Their pathological process and the clinical presentations are different. So we must understand what is basically called internal disc disruption, what is prolapse disc, and what is canal stenosis. So I'll be trying to answer this question, but before that, a little bit of anatomy. That is also very important. So as we all know that the disc has three parts. Most important part is your annulus. So this is the annulus. This is a fibrocartilaginous structures and which is giving the disc height. Two vertebral bodies are not coming closer because of this annulus only. They are very tough boundary wall, and there are 15 to 25 lamellas are there. Lamellas are layers. Annulus has the different layers, and these are known as lamellae. So this 15 to 25 lamellas, and they are arranged in a crisscross arrangement. One lamellae, if fibers are in this direction, second lamellae will be in the opposite direction, so that reinforcing the the strength of this lamellae, of this annulus. Annulus has three very important functions. What are those three functions? One function is inside what is there? Nucleus pulposus. Nucleus pulposus is a soft gel-like thing, and it will be always having a tendency to leak. But annulus is so tough that it is not allowing it if the annulus is healthy. Second important function of the annulus is what? As you already told earlier, that only the outer 1/3 of the annulus has the blood vessels and the nerve, sympathetic fibers. Rest 2/3 of this annulus and whole of this nucleus pulposus do not have any nerves. So now the blood vessels are also there only in the outer 1/3. Is there any live cells inside? Answer is yes. Chondrocyte cells are there inside. So how they are surviving without having the oxygen supply, because they don't have the blood supply. So how they are getting these nutrients and oxygen? Answer is by the diffusion from the periphery to the inside. So annulus supplies the nutrition to the whole. Nutrition is also coming from the end plates. This is the superior and the cartilaginous end plate, one is above, and that is the third important structure. But mostly it comes from the annulus, from the periphery. And remember one very important information, that this fluctuation of the the nutrients and the supply of the nutrients and the oxygen is facilitated by fluctuation of the interdiscal pressure. Means if the interdiscal pressure is sometimes high, sometimes low, that is the driving force. If the interdiscal pressure is always kept constant, like if you are keeping a patient always in the bed rest, or you are sitting in the chair in the whole day, sitting erect with a ergonomically designed chair. We are very fascinating about the ergonomically designed chair. So it's not healthy for the disc. Why? Because the constant pressure, whether it's low pressure like lying down or it's high pressure like in the sitting, none of them are driving the nutrients to the inner side of the disc. So for that, you need to have the fluctuation of the disc. So if you're asking me now question, what is the best position for for the sitting and the looking and the doing the desk job? What will be the answer? Answer is that you should not be sitting in the same posture. No, don't lean forward like this or don't be like this. So you should be sometimes sitting like this, sometimes sitting like that. So that, or sometimes standing. I always tell my patients that every half an hour, take 2 minutes break. Just stand a little bit, walk a little bit, and again sit down. So what will happen? Standing decreases the disc pressure than sitting. Lying down decreases the maximally. So you need to have a high pressure and low pressure, changing pressure, and that is the driving force. So this is the second important function of the annulus, that it is driving the nutrients and the oxygen to the inside the disc. And third important function of the annulus is you're maintaining the disc height. As I already told you, the fibrocartilaginous structure, disc height is maintained by the annulus. If the annulus is not tough, if it is degenerate, what will happen? The two vertebral body will be coming closer. And what will happen? The bulging of the disc, the canal diameter will be narrowed, and we call this condition as a spinal canal stenosis. So if a small segment of the disc is degenerated, that means the nucleus pulposus will come in. And remember always that the disc degeneration means degeneration of the nucleus pulposus. The annulus fibrosus. Nucleus pulposus may be getting dehydrated in a pathological disc or even normally naturally in a elderly people. So what happens when we are growing older? Then the chondrocyte cells inside the nucleus pulposus are less in number, so that the osmolality of the, how the nucleus pulposus is maintaining its 80% water. This is by the osmolality. Osmolality means the two driving force are there. So water inside, one is interdiscal pressure, which will be trying to force the water out, and another is your oncotic pressure, which is trying to keep the water inside. And this oncotic pressure is maintained by the high molecular glycoprotein molecule, which are most abundant is the aglycan, and they are basically laid down by the chondrocyte cells. So if the chondrocyte cells number is less, then glycoprotein molecule will be less. So less water, and this will be, this is aging process. So aging process, disc will be naturally dehydrated. So if I'm asking this question, in disc degeneration, which part of the disc, because there are three parts of the disc, is getting affected? Answer is, it's not the nucleus pulposus. It is the inner layer of annulus. Why not outer layer? Because outer layer has abundant blood vessels. So nutrients are rich supply. So that is not getting degenerated. Degeneration always starts from inner layer. And if that degenerated, what will happen? It will not be able to hold the nucleus. So nucleus will start leaking. So based on how much nucleus pulposus is leaked, we are having the grading of the disc degeneration. So come to the next point, next slide. So this is your modified Dallas classification. This is the degeneration disc, classification, and based on the discography. We inject the dye and we do the outer one third, but it is not leaking because outermost membrane is the outermost layer is still intact, and there is no circumferential spread as well. So it is coming up to the outer. There is circumferential spread, but no outer leaking. That is your grade 4. And if there is leaked outside, then we call it a grade 5. So this is the disc degeneration. So how you can understand that the nucleus pulposus very important function is the holding the nucleus pulposus, the most important function of the annulus holding of the nucleus pulposus. And when the disc is degenerated, it is the how to understand that disc has been degenerated by seeing the leaking of the nucleus pulposus. But another important sign of the disc degeneration is what? Is your loss of disc height, because it is giving the height. So if the loss of disc height is there, that is also very important sign of the disc degeneration. So which Dallas grade is less likely to be responsible for the discogenic back pain? I'll be discussing this point, but let me answer this, see what you are answering. So answer is 5. Less likely, I told you. So you see, if I'm going back to the earlier slide, you see that first I'll be talking about the internal disc disruption. Internal disc disruption, what will happen? Nucleus pulposus is leaked and it is there inside the annulus. So what will happen to the body? Body's reaction? Body is seeing that there is a leakage of the nucleus pulposus, and this nucleus pulposus, remember, is segregated from the body's immune system from the fetal life because the blood vessels are quite away from it. So it is not coming in the immune system. So when it comes first time in the immune system, so it will having a strong immunological reaction. So body will try to repair the disc. How? By neovascularization. So whenever there is a disc degeneration, blood vessels which was there only in the outer one third, they start growing inside. And when they will meet, the meeting is not pleasant. There will be strong inflammatory reaction because of this unknown foreign material. Body thinks that this is a foreign material. So it tries to engulf it. So these reactions which will be causing the edematous zone in this, we call it hyperintense zone. Also in the MRI, it is called the annular tear. And that is what is internal disc disruption. Internal disc disruption means the externally it is fine, but when you're having a cross section, you can see the disc is leaking inside, the blood vessel has grown inside, there is inflammatory zone within the annulus, and that causes the back pain. What will be the back pain? This here. Here the nerve root is not involved. Nerve root is there outside. They are not involved. So there will be no radicular leg pain. Only the back pain, which will be diffuse. Why? Because here the sympathetic nerves predominate. So more than 90% nerves are sympathetic, which is innervating the disc. Only 10% are the somatic fibers. So because it's a sympathetically mediated pain, like when you have the abdominal pain, it is a poorly localized pain. Any pain which is mediated by the sympathetic, because sympathetic fibers is a non-dermatomal. Sympathetic fibers don't have a dermatomal value. You can give a range, like abdominal viscera. Range is from T5 to T12. You cannot say that, okay, this fiber is coming to the appendix. You cannot say that this segment is coming to the gallbladder. We can tell a level, the range, because the sympathetic fibers do not have a dermatomal value. It's a mixed up. And that is the reason why the pain also becomes diffuse. So back pain also, the disc pain also, because it is mediated, innervated by the sympathetic fibers, it will be diffuse. So it will be diffuse back pain, which is aggravated on sitting. Why aggravated on sitting? Because these fibers, which are sympathetic fibers, which are also inflamed, because blood vessel is going in, nuclear pulse is going in, there is inflammatory reaction zone. So sympathetic fibers in that zone is also getting inflamed. And whenever you are sitting, because of the rise of the interdiscal pressure, those sympathetic fibers will be getting more irritated, and that will cause pain. Lying down will be relieving the pain. There will be non-dermatomal distribution towards the back of the thigh and the back of the leg. It will not be dermatomal. There will be no neurodeficits. When the nerve root is getting impinged, there might be neurodeficits. Sensory deficit, motor deficit might be there. But in the internal disc disruption, we call it as a discogenic back pain. So that is not going to cause any neurodeficits. Sitting is painful. Sitting to standing is little less pain. Lying down completely relieves the pain. Walking is not causing any leg pain like the disc prolapse or the canal stenosis. So this is internal disc disruption causing discogenic back pain. Right? What is disc prolapse? Disc prolapse is when this is bulged and compressing the nerve, or leaking and compressing and causing the inflammation of this nerve. What will happen? This nerve root has a dermatomal value because it is a somatic nerve. Say, for example, if the L5 nerve root is getting inflamed or impinged, then what will happen? The pain will be along the L5 dermatome going up to the great toe. Then pain is a leg pain. And this is your predominantly leg pain. This is prolapsed disc. So prolapsed disc means the nerve root is getting involved. And in the lumbosacral area, patient will be presenting as the leg pain, dermatomalloid distributed leg pain, neurodeficits might be there, and sitting, please remain muted. Sitting will be decreasing the pain. Why sitting will decrease the pain? Because sitting causes relaxation of the nerves, particularly the lower lumbar nerves. When we are sitting, we are flexing the hip and the flexing the knee. Flexing hip and knee relaxes the lower lumbar nerve roots. So sitting causes the relief of the pain. Standing and walking will increase the pain. So this is your prolapse disc. It's the second important presentation of the disc pathology. And third important presentations, I'll be coming to that point later on. Just let me quickly go through this. Then so disc as a pain generator. One, I already told that the internal disc disruption. Second is your prolapse disc. And third is your canal stenosis. So canal stenosis is what? As I told, that it pathology starts from the disc. So the disc, when the significant portion of the disc is degenerated, so that the height of the nucleus of the two vertebral body will be coming closer. So disc will be bulging from anteriorly. So there are basically three components of the canal stenosis. So canal stenosis will be having three important parts. One is because the two vertebral bodies are coming closer, the disc will be bulging, and that will be compromising the disc from the anteriorly. Now, if the two vertebral bodies are coming closer, what will happen to the lamina? Lamina will also come closer. And if the two lamina is coming closer, what is there in between? There is ligamentum flavum is there. So ligamentum flavum will be folded and going anteriorly in this V-shaped manner. And that is known as the ligamentum flavum hypertrophy. So it causes the narrowing of the canal from posteriorly. And third component of the canal stenosis is your what? This facet joint will be also hypertrophied, because if the two vertebral bodies are coming closer, there will be overloading of the facet joint, which will cause the facet joint hypertrophy, and facet joint hypertrophy will be causing the narrowing of the canal from the posterolaterally. Most of the time, these three components are together, and they causes the narrowing of the effective cross-sectional area within the spinal canal. So what will happen? If the cross-sectional area is raised, then first to be affected is your blood vessels, because they are the most compressible structures. And remember, when we sit, patient will not feel any symptoms. Why? Because of the two reasons. Number one reason is that the nerves needs less oxygen supply. Why? Because they're not working. But at the same time, when you sit, what do? You do the flexion. If there is a flexion of the lumbar spine, the the lamina will be separated. If the two lamina are separated, ligamentum flavum will be stressed. So what will happen? The effective canal diameter will be increasing. And that is the reason why the canal stenosis patient feel very comfortable on sitting, because they don't have any, the canal diameter is increasing. And the nerves needs less oxygen. But when they'll be standing, the dura will be pushed up, so they'll be having the back pain. And when they will walk, there'll be ischemia of the nerves, so they'll be having the claudication. So these are the three important pathophysiological, explanation of the different kinds of disc as a, the pain generator presentation. So let us go to the next slide. So what will be the clinical feature then? Clinical feature, internal disc disruption or degenerated disc will cause the discogenic back pain, and pain will be more on sitting. Next is disc prolapse. It will be leg pain, which is relieved on sitting, lying down, increased on standing and walking. And canal stenosis, it will be having neurogenic claudication. So pain will be on walking, and that pain is different from the vascular claudication, that it will be having some tingling sensation, some heaviness, some numbness. So any of these features must be there to call it as a neurogenic claudication, or you also call it as a pseudo claudication. True claudication is a vascular claudication. Here it's a neurogenic. Here is also vascular claudication, but here is the vasculature of the nerves in the spinal canal. We call it neurogenic claudication, or the pseudo claudication. Now, so this is about disc. Now we'll be coming to the other things. More than 80% of the elderly. Okay, so another very important part, let me cover that. Then we'll be coming to the facet and other things. Look at this statement. Is this true or false? More than 80% of the elderly have the disc bulge, even without any back pain. or back pain or leg pain? Okay, all of you answered right, and I'll be coming to this statement. Very important statement, and it was the meta-analysis done in 2000, 2015, and lot more data because I was getting this article is very good meta-analysis, but there are a lot of other even the recent publication is there. So what was there in 33 articles, and you see 3,110 asymptomatic individual. Very important is their asymptomatic individual. And what was the MRI findings? Disc degeneration the 37% in 20s, 37% and 96% in 80s. Disc bulge 30% in 20s and 84% in 80s. Disc protrusion 29% in 20s, 43% in 80s. Annular tear 19% in 20s and 29% in 80s. So, what should we learn from this? That if you are treating your patient based on the MRI, how many percentage of time you'll be doing wrong? In 80s, 85% situations you might be doing wrong. So what is very important? Very important is the MRI should be giving importance only when it matches with your clinical features. So clinical features understanding is very, very important. Many times there is asymptomatic disc, but pain is really coming from the facet joint, or pain is coming from the muscle, or pain is coming from the sacroiliac joint. So only looking at the MRI, if you are treating the patient, you might be wrong in more than 50% situation. So try to evaluate the patient nicely. Try to understand where from the pain is coming by different clinical features. I'll be coming to the clinical features, other clinical features later on, and then we can do the justice. Now, incidence of the back pain where the pain generator is not disc. So we talked about the disc. Now I'll be talking a little more about the other pain generators. Okay. So the right answer is your 60 to 70% is other than disc. Other than disc, already have discussed, fascia joint is the second common cause of the back pain. So if the answer question is where question answer is your facet, then why question answer is what are the causes the facet joint can be a painful facet joint? It can be degeneration, it can be inflammation, particularly the ankylosing spondylitis or other spondyloarthropathies, and trauma, rarely malignancy, very rarely infection. So how many percentage of the back pain is because of the painful facet joint? Second common cause of the back pain. First common cause of the disc, it's approximately 15 to 45%. Here it is your 20 to 25% of the pain, back pain, total back pain is because of the facet joint. So now facet joints are two synovial joints, and one on the right side posterolaterally, another is left side. And how the facet joint can be loaded? If you are doing the extension, lateral bending, and rotation, then this facet joint is basically loaded. So, and when it is unloaded, when you flex forward, facet joint will be unloaded. So based on this information, you can understand what will be the patient's symptoms and signs. So patient will be comfortable on sitting. Why? Because when you are sitting, you are flexing. So facet joint will be unloaded, so there will be no pain. Sitting to standing will be painful. On walking, again pain will be less, unlike that of the prolapsed disc or canal stenosis. Here the walking will not produce any pain. Mostly not pain. If you are having the prolonged walking, then might be having pain. Otherwise, facet joint is mostly painful when sitting to standing, and extension, and rotation, and lateral bending. And there will be no neurodeficits unless it is associated with the disc. Only facet hypertrophy never produces any neurodeficits. Most of the times, facet hypertrophy is associated with the disc, and that can cause the neurodeficits. And the pain will be decreased on walking. So these are the clinical features, salient clinical features of the facet. Facet mostly presents lumbar facets at the buttock and the back of the thigh. Posterolateral aspect of the thigh is the common referred areas. The less common referred areas are your back of the leg, inguinal areas, lower abdomen, and least common is beyond the foot, in the foot, beyond the ankle, and in the abdomen. They are the least common areas. So if you are looking about the common referred area, the common referred area is the buttock and the posterolateral aspect of the thigh. And medial and the anterior aspect of the thigh facet joint referred pain is not seen. Okay. Next is your sacroiliac joint. So again, like facet joint was loaded on the extension, lateral bending, and the rotation. How the sacroiliac joint can be loaded? So then you can understand then when the pain will be aggravated. Sacroiliac joint is loaded when somebody sits. So sitting aggravates the sacroiliac joint pain because it loads. But at the same time, prolonged standing also can cause the loading and gap pain. But what are the causes of the sacroiliac joint pain? Degeneration, inflammation, malignancy, trauma, and infection also. Tubercular infection has also been reported as a cause of the sacroiliac joint. And what is the prevalence of the SI joint pain in the lower back pain? So 15 to 40%. Clinical features: patient will present as the lower back pain or the buttock pain, and which is well localized. This is known as 14-finger test, right? With non-dermatomal leg pain, again mostly in the anterior aspect, the posterior aspect of the thigh and the posterolateral like facet. But here the pain can be referred on the inner thigh or anterior thigh as well, and sometimes in the leg, sometimes rarely in the foot, and in the inguinal area, the pain might be referred. The pain increased on sitting and relieved on standing or walking. Again, pain might be increased on prolonged standing also, and there will be no regular visits like that of the facet. Next come muscles. Muscles, again, myofascial pain in the back, most commonly because of the repetitive stress injury, trauma, prolonged muscle spasm, or sometimes because of the malignancy. This muscle spasm is basically myofascial pain. If you're stretching the muscles, pain will be reproduced. And here the very important is your piriformis, because just anterior to that is your sciatic nerve, and myofascial pain because of the piriformis can mimic the sciatica. And also the QL, quadratus lumborum, and the psoas, if there is a spasm of those muscles, there can be compression of the lumbar plexus. So that can also present as a radicular pain. So both few of these muscles can cause the mimicking of this radicular pain, and we have to always be cautious that whether this muscle is the cause of the back pain or not. So the QL and the psoas muscle. Here is the piriformis muscle where the sciatic nerve is coming. Here the lumbar plexus is formed within the psoas muscle. So the other myofascial pain where the pain might be mimicking the radicular pain. Okay. Now quiz: myofascial pain of which muscle is responsible for the pseudo sciatica? Okay, most of you answered. Just now I have told that it may compress the sciatic nerve and it causes pseudo sciatica. Okay, then is ligament. It can be sprain, trauma, or sometimes enthesiopathies of the ligament can also cause the pain. It's basically inflammation. And the few ligaments are very important. Most important, very closely mimics disc pathology is your interspinous and the supraspinous ligament. There are many other ligaments which can be responsible. Then is your vertebral body. As I told you earlier, the earlier vertebral body trauma malignancy was the only cause which was giving importance. But nowadays, the inflammation of the vertebral body seen in modic changes are also giving equally importance. So vertebral body can also be a cause of the back pain. Then is a different bursa, the ischiobutyral bursa, trochanteric bursa. So this bursa, when inflamed, can again cause the lower back pain. Hip joint. Hip joint always be included. Sometimes posterior hip pain, which is radiating down, patient is unable to stand or have difficulty in stand. So these all can mimic the hip pathology. And in fact, I have seen this kind of patient where there is an impacted neck femur fracture, and patient was having the MRI, which is showing the disc prolapse, disc bulge, and patient was posted for the operation. I have seen this kind of patient. So always, whenever you'll be getting this patient, always examine the hip. Just do the different movements, means flexion, extension, internal rotation, external rotation. So just do this movement, whether all these things are non-painful and the range of movement is fine. Even then you can some suspect some hip pathology is there or not. Okay, so evaluation back pain. First part is your causes and its clinical presentation. I'll be coming with the next few things. This next part of this presentation with the we'll be starting with the red flag and the different clinical the examination part. Okay, now quick quizzes, whatever you have discussed. And before that, which one is a red flag? Red flag I'll be discussing in detail next subsequent topic. Excruciating pain, mild numbness, unable to hold urine, and severe trauma. Which one is red flag? So red flag is severe trauma. Unable to hold urine is not a red flag. Unable to pass urine is a red flag. I'll be discussing that later on. And excruciating pain is not a red flag because pain has a lot of other factors. Pain and tissue damage do not go hand in hand. Mild numbness is also not a red flag. What increases the pain in disc prolapse? Lying down, sitting erect, standing, sitting and leaning forward. So standing increases the pain. Sitting erect, sitting and leaning forward do not increase the pain in disc prolapse. Why? Because when you are sitting, we are flexing the knee. So flexing the knee and hip will cause the relaxation of the nerve root. So disc prolapse, what is the hallmark? Pathology is where it is the nerve root compression and the inflammation, irritation. So that will be, nerve root will be relaxed on sitting, either erect or leaning forward, whatever it is. But standing will be stretching the nerve root. So standing and walking will increase the pain in the disc prolapse. Facet pain increases on walking. So facet pain increasing the walking is a false. Mostly facet pain will be increasing on sitting to standing and extension lateral bending rotation. Walking will not increase. Walking will increase the pain in the disc prolapse and the canal stenosis. And sitting also will not increase the facet pain. Which is most commonly affected in spondyloarthropathy? Spondyloarthropathy means inflammatory disease of the spine, which includes the ankylosing spondylitis, reactive arthritis, psoriatic arthritis. All these together are known as spondyloarthropathies. So which is most commonly affected? Disc, sacroiliac joint, facet joint, piriformis. There is a sacroiliac joint. Sacroiliac joint is most commonly affected. Facet joint is also affected, but the sacroiliac joint is a hallmark of spondyloarthritis. What is the clinical feature of canal stenosis, spinal canal stenosis or lumbar canal stenosis? Leg pain on sitting, back pain on walking, back pain on sitting, leg pain on walking. So it is leg pain on walking. We call it neurogenic claudication. And there should be some other neurological features like tingling sensation, numbness, heaviness, weakness. Some of these might be there. Bursa pain is commonly due to inflammation. True or false? Okay, so it's true. Sacroiliac joint pain increases on sitting. True or false? Yes, it's true. Facet pain is most commonly because of degeneration. True or false? So degeneration is the commonest cause of the facet pain. What increases the pain in facet joints? If it is a facet joint pain, what will be increasing the pain? Walking, lying down, lateral bending, sitting. So lateral bending, because facet joint can be loaded with the extension, lateral bending, and rotation. Muscle spasm can cause back pain. True or false? What is the most common clinical feature of the sacroiliac joint pain? Walking pain, neurodeficit, leg pain, buttock pain. Yes, buttock pain is the most common clinical feature. Okay, so this much. So let me see the first part. Who is the top scorer? Then I'll be coming to the second part. So AP, I don't know who is AP. Is it Anirudh Pai?
Yes, sir.
Okay, okay. Okay, congratulations. So now I'll be coming to the second part. So let me stop this. Okay, any questions from the first part? If you are having any questions regarding the first part, you can. Anybody have any question? Okay, now we'll log in again. This is a separate login. Pin is coming. Quickly log in, then I'll be going starting the second part. It's almost 1 hour, but I'll be continuing another half an hour, 40 minutes. Is it okay? Hitesh and others?
Yeah, yes, sir. No problem. Please continue. Hello.
Yes?
Yes, sir. We are happy to hear you. Please.
Okay, okay. Thank you. Thank you.
Thank you, sir.
Anybody else wish to join or shall I start? As I told, without joining also you can, there is no problem. Without joining Kahoot also you can just go on to see the lecture. So if you have a second device, just with your mobile, you just scan the QR code. It will be asking your name, put any name, and then you can start. Okay, let me start. So steps of evaluation, what we'll be discussing now. So initially, as I told you, total evaluation part, first part is your causes. And I have discussed a little bit of epidemiology also and the different clinical presentation. And now we'll be going ahead with the different, the test and common clinical test we'll be talking. But again, we'll be starting with another quiz on the red flag. What is the red flag of the back pain? Okay, so I'll be coming to this point. And I always tell what is the eligibility to start a pain clinic. I always tell that the most important, eligibility means you must have ability to eliminate the red flag. If you can't, then you are not eligible. And not just back, for the headache, for the shoulder pain, for any pain. You must be having, you might not be making a proper diagnosis, no issue. But you cannot miss a dangerous diagnosis. That is the very, very important criteria, that dangerous diagnosis must be, diagnosed properly. At least you should be suspecting it. And if you're suspecting, you should be consulting your neurosurgeon friend or orthopedic surgeon friends. So, again, the steps are causes of the red flag, then history, examinations. I'll be talking about this today in this part, and the other part also there, but today I'll not be covering that. So first is the red flag pain generator already have discussed. So I'll be discussing little more about this. So red flags, one of the red flags is a major trauma. Major trauma includes a fall from height, or the road traffic accident, or if you're suspecting any tumor, like somebody is having a CA lung, CA prostate, CA ovary, and he is or she is complaining of the back pain also. So you should be always suspecting the tumor. Or somebody is having the anorexia, cachexia, unusual weight loss. So you should be also suspecting a tumor. And if this patient is having the back pain, suspicion of the infection. If the patient is having the fever, along with that, patient is having the infection, means general infection is not important, but if infection is involving your spine, so neck rigidity, Carney sign, so this all be very dangerous signs. Then if you're suspecting fracture, not only history of trauma, if you are having an X-ray and you can see there is a fracture, is always a red flag. And then come a very important part, what we have to evaluate is your neurodeficits. Neurodeficits can be divided into three broad categories. One is your autonomic, one is your motor, another is sensory. Severe pain is not a red flag, as we discussed earlier also. Most important here is your autonomic. So I'll be talking a little more about the autonomic fibers, and none of you must be missing this autonomic dysfunction, the features. So autonomic fibers are, if you can remember the basic anatomy, are the divided into sympathetic, parasympathetic. Sympathetic is also known as the thoracolumbar outflow. So it starts from T1 till L2, where the lateral horn is there, the cell body, second the neuron, first order neuron, from where it is coming along the nerve root. So the sympathetic fibers are there within the spinal canal. At which level? T1 to L2. After that, it is coming outside and it is forming the chain outside the spine. So just from the cervical area till the coccyx area, there is a sympathetic chain which is outside. But where from they are coming? These fibers are coming from T1 to L2. That means within the spinal canal, neither in the cervical area nor in the lumbosacral area, there is, except below up to L2, there is no sympathetic fibers within the spinal canal. This is very, very important to remember. No sympathetic fibers within the spinal canal at cervical level and the lumbar and the sacral areas. Mostly it is in the thoracic areas. So sympathetic chain is there outside the spinal canal. So any spinal canal pathology at the lumbosacral area is very less likely to cause the damage of the sympathetic fibers, right? Because within the canal there is nothing. If there is anything pushing, fibers will be also pushed. If it is within the canal, if something is happening, then there will be damaging. Like suppose a big prolapse disc, or there is a big hematoma, or is a fracture fragment which is compressing the nerve. Everything happens inside the canal. If it is outside the canal, the fibers will be escaped mostly. What about the parasympathetic? Parasympathetic is known as craniosacral. So the cranial nerves, few cranial nerves, and the sacral nerve roots, S2, S3. That means parasympathetic fibers comes down till it comes into the sacrum, and S2 and S3 it comes outside to form the plexus and then innervates the bladder. So if there is any lumbosacral pathologies causing back pain, which fibers will be affected? Answer is simple. It's a parasympathetic, not the sympathetic. Right? So understand this very nicely so that you'll be able to understand the whole, the bladder bowel symptoms if you understand this one. So remember, lumbosacral pathologies, sympathetic fibers are escaped because they are outside the canal. Parasympathetic fibers are damaged because they are inside the canal, because they are exiting through the S1, S2. So now, what are the functions of the sympathetic and parasympathetic? Sympathetic fibers causes the constriction of the sphincter. Let me come to the bladder first. Constriction of the sphincter, relaxation of the detrusor muscle, so there will be retention of the urine. Parasympathetic fibers, what is the function? Its function is contraction of the detrusor muscle, relaxation of the sphincter, so it helps in voiding the urine. So now in the lumbosacral pathologies causing the back pain, which fibers are affected? Parasympathetic. So what will be the features? It is the unopposed sympathetic function and unable to pass the urine because the detrusor muscle is not contracting, it is relaxed by the sympathetic fibers. So unable to pass urine is a red flag, but unable to hold the urine is not the red flag. Right? Unable to hold the urine, not only the sympathetic damage, there might be the many other causes for the unable to hold the urine, but unable to pass the unable to hold the urine, but unable to pass the urine is the red flag. Then comes to stool. What will happen to the stool? In the bowel, it is little, the twist is there. What is the twist? So you remember when the parasympathetic fibers are damaged in the lumbosacral canals, so there are not just parasympathetic fibers. What else are there? All the lower motor neuron fibers are there, caudate fibers are there, and they all are lower motor. And our bowel, our anus, has two sphincter. One is internal anal sphincter, which is supplied by the autonomic, sympathetic, parasympathetic, and another is external anal sphincter, which is innervated by the somatic motor fibers. It's basically the voluntary muscle. So that means if all the fibers, so lower motor fibers as well as the parasympathetic fibers are damaged, what will happen? External anal sphincter will be relaxed because there is a flaccid paralysis. Lower motor neuron paralysis means flaccid paralysis. There will be perianal anesthesia. So if you are doing a rectal examinations, patient will not feel anything because the perianal anesthesia is there. Like in the anesthesia, we do the saddle block, no? So you are blocking all the the lower motor neurons, sympathetic, parasympathetic, and the lower motor neurons, as well as the sympathetic somatic fibers. So rectal examination, patient will not feel anything, and the sphincter, the tone will be very relaxed. And what will happen to the internal anal sphincter? Internal anal sphincter will be constricted. Why? Because the sympathetic fibers are not affected. It's the parasympathetic fibers. Sympathetic fibers are escaping the lumbar area at the level of the L2. Below L2, there is no sympathetic fibers. So in the lumbosacral pathologies, parasympathetic fibers is affected. So there will be constriction of the inner sphincter and dilatation on relaxed external sphincter. So it's very ironic to understand why the patient is unable to pass stool, because they are having the anal sphincter tone is very relaxed, but that is external anal sphincter. Remember these things. So these are the most dangerous. Surgery to be done, surgical decompression should be done within 48 hours, 2 days. Otherwise, the patient might be permanently on the catheter. Permanently, they have to manually evacuate the stool. So this can happen. So always remember, the autonomic nervous system is very, very important. Then comes motor. Mild motor weakness is not considered as a red flag. So if it is a grade 4/5 motor weakness, it is not a red flag. If it is a 3 or more, then it is a red flag. Sensory, again, the static sensory disturbance is not a red flag. If it is a progressing sensory deficit, then you call it as a red flag. And severe pain is not a red flag, but severe pain not relieved by the pharmacotherapy or other analgesics, then it is considered as an EORO flag. So remember the red flag very nicely, particularly autonomic symptoms is very important because 48 hours, within 48 hours, the surgical decompression should be done, otherwise you are not going to get the good results. Motor deficits, surgery should be done within 4 weeks. Sensory, it is not considered red flag unless it is gradually progressive. Okay. So now again, so the cause is red flag. Now history. History chief complaint. Chief complaint we should be noting about the the most important complaints. It's pain intensity as well as your duration. So this should be mentioned the chief complaint. Then history of present illness. Detail of the history I am not going. And those who are the not from Darodia, they can, I'll be requesting them that they can history taking. I am having the YouTube videos are there. You just go through that, and all the steps are very important. Here the intensity, quality, aggravating and the relieving factor, diagonal variation, everything you have to know nicely. Family history, medical history, personal history, occupational history. This history taking itself is a long part, and the most important time given in the evaluation part should be the history part, because that will be giving you the maximum clue in your diagnosis. I'll be focusing more on the clinical examination part. Clinical examination part, as I told you earlier, in pain medicine, the other steps: inspection, palpation, range of movement, both active and passive range of movements, neurological examinations, and special clinical tests. So first is inspection. Inspection, what you will see? Posture, how the patient is sitting or tilting one side, or lifting the one side buttock, like in the, suppose somebody is having the ischial tube, the bursitis, patient will not be able to put pressure on the one side, or patient is having the coxsackie will be leaning forward. How the patient is walking, what is the gait, whether it is a antalgic gait, tendicular gait, like lots of other different types of gaits are there. So these will be also giving you some clue. The muscle size, shape, contour, the color of the limb, swelling, scar, all those things should be inspected, and preferably you should be exposed to the affected part side, and you should be inspecting this. Then is tenderness. Tenderness is a very valuable clue for eliciting the, where is my pain generator. It can be joint, like facet joint can be palpated, the sacroiliac joint can be palpated. If it's a bursa, like ischial bursa, trochanteric bursa, if it's a ligament, supraspinous ligament, muscle and tendons. So this palpation gives very valuable clue. But remember, deeper structures can be palpated. Can you palpate nerve root? Answer is no. Can you palpate vertebral body? Can you palpate disc? Answer is no. So anything posterior to the spinal canal can be palpated, but spinal canal itself and anterior to that, you can't palpate these structures. Psoas can you palpate? Answer is no. Quadratus lumborum can be palpated? Yes, with difficulty. Erector spinae muscles can be palpated. The gluteal muscles can be palpated. The deep palpation you can palpate even the piriformis muscle as well. So palpation eliciting or tenderness is very important, and that will be telling you where the pain generator might be. Then is range of movement. One very basic information of the range of movement is active and passive. If both active and passive, active means patient himself is doing the movement. Passive means you are doing the movement, not the patient. So if both active and passive are involved, then it is likely to be the joint pathology. But if it is only active and not the passive, so it is an extra articular pathology. So this is the basic things for any joint whatever you are evaluating. So now here, hip and spine both should be examined: flexion, extension, rotation, lateral bending. And for the hip, abduction, adduction, all this movement should be done, both active as well as passive. Then neurological examinations. And always include the upper motor neuron disease, upper limbs also. Because many times the patient might be having the difficulty in walking, and the pathology might be in the cervical area or thoracic area. So full neurological examination is important. Never miss examination of the upper limbs. Then special clinical test. Special clinical test for the lumbar nerve root irritations. Special clinical test for the lumbar cluster stenosis, sacroiliac joint, and piriformis myofascial pain. So first is your lumbar SLR test. All of us are doing it, but few very important things is remember that if you are raising the leg and pain in the back, not in the leg, then that is not called SLR positive. And SLR positive, if it is between 30 degree to 65 degree, then it is specific to the nerve roots. But this nerve root is a lower lumbar nerve roots, means L5, S1, S4 also sometimes. But above that, it is not important, because sciatic nerve root value is what? Is L4, 5, and then S1, S2, S3. So this is particularly for the nerve root which is forming the sciatic nerve. For the lumbar plexus nerve, femoral and others, you need to have this test. This is your reversed SLR test. Here you will be stretching the femoral nerve if you are doing the extension of the hip. So remember, if this was SLR was for the lower lumbar, L4, 5, S1, and this is for L1, L2, L3 is your reversed SLR test. Then come spinal canal stenosis test. Stoop test, as I told earlier, when we are flexing forward, we are increasing the diameter of the spinal canal. And there are several tests. One is stoop test. Another is shopping cart sign. Shopping cart sign is what? If you are holding the shopping cart, you are basically flexing. So your spinal canal diameter will be increasing, and the patient will not be having pain. And Kemp test is opposite. Kemp test is ask the patient to do the extension. If you are doing extension, what will happen? Two lamina will come closer. Ligament of lamina will be hypertrophy, will be pushing further and narrowing the canal. So extension causes pain. And another very important thing is climbing upstairs will be comfortable, because when you climb upstairs, you lean forward. And climbing downstairs means you do the extension, that will be more painful. That will be having the leg symptoms more aggravated. That is similar to that of the chem test. So chem test is extension, and sometimes if it is the patient is having the unilateral stenosis or called as lateral canal stenosis, then you should be asking the patient to do a lateral bending on the affected side and see whether the leg symptoms are reproduced or not. If it is, then it is positive. Then comes your sacroiliac joint test. You see, so many sacroiliac joint tests are there. And normally we call, if 3 tests are positive, then take it as a positive. What are those? One is distraction. You are pressing on the both anterior sacroiliac spine and see whether the affected side has a pain or not. Then thigh thrust. Distraction is for both the together, both the SI joint together. Thigh thrust is one by one. So you are pressing the pressure in the hip and knee in 90 degree, and you are pressing directly, putting thrust there on the sacroiliac joint on this side, left side. Sacral thrust. Again, this is for both the joint. If you are putting pressure on the over the sacrum, pressing it and see whether the pain is there or not. Gensler's test is again for the both the side. So one leg will be hanging like this, another you are flexing, and you see whether the pain is reproduced or not. Compression test also for the both the side. So you are asking the patient to be a lateral side, and you are compressing it and see whether the affected side has pain or not. And Faber test. Faber full form is what? Flexion, abduction, external rotation, and that causes stress on the sacroiliac joint, but also it is for the hip joint. So remember, Faber test is not specific for the sacroiliac joint. It is for both hip and sacroiliac joint. For the sacroiliac joint, it will be producing back pain. For the hip joint, it will be mostly producing the anterior hip pain. And if 3 is positive, then you can call it clinically as sacroiliac joint positive. Then comes the piriformis test. Piriformis muscle is, what is the origin and insertion? It is on the lateral border of the anterolateral border of the sacral S23, and it getting inserted at the tip of the greater trochanter. So what is its function? It causes the abduction and external rotation. So to stress the piriformis muscle, you have to do opposite. That means adduction and internal rotation will be causing your pain in the piriformis muscle. So this will be Freiberg's test. If you're doing internal rotation, external rotation, with the internal rotation, pain is reproduced, external rotation, pain is relieved. That is Freiberg test. Faber test can be done in the Fair test. Fair means flexion, adduction, internal rotation. It can be done in the lateral position. Also, it can be done in the supine position and lateral position. What do you have to do? You have to press on the knee and you have to lift the leg. And that is basically doing the internal rotation and adduction. British test is almost similar. Here, the one leg will be straight, another leg you are flexing and putting pressure on the knee only. And that will be causing the adduction. So both of these tests are similar. Lateral position Fair test and the British test. And they'll be again aggravating the pain on the buttock. So these are the tests for the piriformis. So before I go to the quiz, just I'll be quickly, remembering what are the tests. So what are the treatment part? So disc, if it is an internal disc disruption, the best treatment, evidence-based treatment is your biacuplasty. Biacuplasty is basically the cooled bipolar radio frequency within the disc. But there are many other treatments which can be tried. One of them is the epidurals. Epidural can give you short-term relief. You can do the caudal epidural, you can do the bilateral. If the patient is having the midline pain, you can do the bilateral transforaminal epidural as well. You can do the interlaminar epidural as well. You can do the disc FX is another instrument which you can do the cauterization of the inside. Apart from that, 2 old procedures are also there. One is IDET. IDET means interdiscal electrothermal coagulation of the disc and the fine nerve fibers, and another is your disc annuloplasty. So there are lots of the radio frequency procedures which can basically cauterize the nerve roots which are there inside. Remember the internal disc disruption, what is the pathology? It is the sympathetic fibers within your annulus. So you have to ablate those fibers for the long-term relief. But for the short-term relief, you can go for the epidurals. Then comes the prolapse disc. Prolapse disc based treatment is your transforaminal epidural. But also you can do the caudal epidural. But remember, if the red flag is there, then the surgery is the choice. Then canal stenosis. Canal stenosis, again, it depends on how much is the stenosis. If it is very severe, having the neurodeficits, then surgery is the choice. Otherwise, epidurals also give a good results. So these are the disc-related pathology. Fascial joint pain. Gold standard for the fascial joint pain is a radiofrequency ablation of the medial branch. But again, the steroid or PRP can be given in the fascial joint as well. Sacroiliac joint pain. Again, the gold standard is your radiofrequency ablation. but we can also think for the cryoablation, we can think for the PRP injection, or for short-term relief, your steroid injection in the sacroiliac joint. For the myofascial pain, you have to do the myofascial trigger point injection. So you can give the local anesthetic. Steroid is nowadays avoided, or you can go ahead with the dextrose injection, like in the piriformis, like in the QL. You have to identify the pain generators there, and you have to treat that. For the bursitis, again, if it is an inflammation, most commonly that it is an inflammation, steroid is the drug of choice. But recent literature is telling that the PRP might also be a choice for the bursa injection as well. So these are the just outline of the treatment, whatever the pathologies we have discussed right now. Now, before end, I'll be going to the quick, some of the, the quiz again. So participate in this quiz. 3 quizzes are there. Which test is for the piriformis myofascial pain? Pair test, scoop test, stoop test, sacral thrust, chem test. So it's the fair test. Flexion, adduction, internal rotation. Which test for the spinal canal stenosis? Clinical test. Sacral thrust, chem test, pair test, SLR test. So it is chem test. Chem test means extension. And if the patient is having the lateral canal stenosis, extension, and same side lateral flexion, affected side lateral flexion, patient will be having the leg pain. Then, which test is for the lumbar nerve root irritation? SLR, chem, pair, sacral thrust. Last quiz. Which test is for the sacroiliac joint pain? But again, remember, one test is not enough for the sacroiliac joint pain. You have to have the 3 tests positive. Okay, let us see who has scored. So AP is third now. Sam. As. Who is As?
Sir Ashwini.
Okay. Okay, Ostini. So thank you very much. If you are having any quick questions, you can ask me. And then we'll be ending today's session. Any questions from anybody? No question? Okay, Hitesh, what to you?
Yes, sir. Thank you, sir. If anybody has a question, please ask the question. I think
Okay, so no
explanation
questions.
is good. So no question is there. Sir, there is a question by Ashwini Gupta. The role of the lumbar belts for the
Okay,
treatment.
role of the lumbar belts is only for the acute pain. Prolonged use of belt is discouraged because if you are doing the limitations of the movement, what will happen? One to already have told, limiting the movement will be decreasing the movement of the disc. Disc will remain healthy when there is a fluctuating pressure of the disc. So we should encourage the movement. We should not be restrict the movement except for the acute pain. If the patient is having the acute pain or acute trauma, then there is a role of lumbar belt is there. That should be for short period, not for the prolonged period. In chronic pain, there is no role of base and belt. And chronic use must not be condemned. It should not be used.
Okay. Thank you, sir. There is one more question, sir. What is the extra-articular pathology? In extra-articular pathology, active or passive movement are affected, sir.
Yes. If extra-articular pathology, passive movement will not be affected. It will be only the active movement which will be affected. If the intra-articular pathology, then both active and passive movement will be affected.
Okay. Any more question? there are a lot of messages of appreciation, sir. And it is always a pleasure to listen to you, sir. Whenever we listen to you, we learn a new thing. You make the subjects very easy, very comfortable, and yet cover all the aspect of the part. Thank you, sir.
Thank
So
you, Hitesh. Thank you, Hitesh, for your nice words. So actually, I have hurried because 1 hour it is difficult to cover the things. So I have hurriedly covered the things, just touching the salient points.
yes, sir, we can understand. Yeah,
Thank you, sir. It was an excellent lecture, sir. Thank you.
thank
Thank
you.
you.
So we conclude the session and we can end the session, Mandri. Yeah.
Okay, okay.
Yeah,
Thank you.
yeah.
Okay.
Thank you.